we're going to be having a discussion regarding surgical pathology, cytology, terminology. This is the first time we're having this session after the program's gone on for many years, but we decided to include this as a new session. This is the first time we're doing this because from past experience we know that all of you come from different programs with varied expertise in the field of thyroid in your program when it comes to your thyroid attendings, but also when it comes to your pathologist and your surgeons. So we wanted you to be able to, when you get a report from a surgeon or a cytopathologist or a pathologist, to be able to understand the terminology, ask appropriate questions to clarify things in your mind, and be able to have a basis from which to communicate with your surgeon and your pathologist. So we're very fortunate that Dr. Asa from the University of Toronto and Dr. Gerard Doherty from Ann Arbor, Michigan were accepting of our invitation to come and participate in this session this afternoon. So we're going to start by having an imaginary case where somebody comes to us with a thyroid nodule, and the patient, based on size and ultrasound criteria, et cetera, as we've discussed, has a fine needle aspiration of their thyroid nodule, and now you're going to get the cytology report. The case will unwind as it'll be a case where the cytology report indicates the need for surgery, and Dr. Doherty will follow up with his surgical report and things we should be looking for in a surgical report, followed by then the pathology report. So we'll have Dr. Asa follow up with the terminology that we should be looking for and questions that we should be asking when it comes to an understanding and interpretation of the surgical pathology. So without further ado, I'll turn the mic over to Dr. Asa after we've done our F&A, and now we have a cytology report to interpret.
So I want to start, first of all, with a couple of issues just about format. So this is really informal, and if you have questions, please don't even hesitate, because we didn't plan this to be a formal presentation, right? The other thing is I will do a disclaimer. You know, all the second slides are disclaimers. I didn't make it a slide because I didn't even know if I'd have slides, but I do have a disclaimer. I'm actually married to an endocrinologist. That makes me not your ordinary pathologist. But apart from that, I'm a pathologist. One other thing that I do want to just mention is that pathologists are very unique people. You know, there's a joke, how do you tell the extroverted pathologist? They look at their hands when they're talking to you, not their feet. So pathologists tend to be kind of very quiet people who work in the background, and they have this unique characteristic that they write reports. And so words are really important to pathologists. Some pathologists are so into their own words that they like to go on and on with lots and lots of flowery descriptions in their reports. But what I want to tell you today is really the important things to understand. The sensitivity of the pathologist is that because we use words to describe what we see in images, we try to be very precise. And pathologists take terrible offense when people reword their reports. So just be careful of that as you go down your career. Pathologists are also very cautious people. We tend to be maybe scared a bit, and very litigious, protective type of people. So a lot of what you're going to see in your practice is because of that. But that's just all the background information. So we have a patient who's come in with a thyroid nodule. Clearly you're worried about it clinically, or you wouldn't biopsy it, right? So you do your needle biopsy, or you may call the pathologist to do your needle biopsy, and you're going to get back a report that has one of these 6-tier diagnostic categories. And for some of you may not be aware of this, but this is actually real progress in the world of thyroid cytology, because it used to be a free-for-all out there. But a few years ago, the NCI did have a meeting, which they couldn't call a consensus meeting, but they came up with a state of the science meeting to actually force pathologists to at least fulfill one of these 6 types of classifications and when they look at thyroid aspirates. You know, it used to be that you could make a report that says follicular cells seen. That's not really very helpful, right? So you put a needle in the thyroid, you're going to see some thyroid follicular cells. We need more than that. So you've got your 6 tiers. How many of you are familiar with this? Most of you. By the way, I did forget to ask a question at the beginning. How many of you are not endocrine fellows? Everybody in the room's an endocrinologist. Okay, so we're the only one of our kind. All right, so we have to support each other here. Okay, so you get back a report that says it's non-diagnostic or unsatisfactory. What does that mean to you? That means that the sample was not good enough for the pathologist to interpret. Don't take anything more than that from a report like that. You need to then go back clinically. Usually you're going to repeat that aspirate, right? Because if you don't have diagnostic tissue, it means that there's a problem with the technical procedure that was performed. If you're doing a needle in an office and you're doing it by palpation, you're probably going to want to say, well, maybe I better do this under ultrasound, right? Because you might not have gotten diagnostic tissue. And the classic example of that is you put a needle in and it turns out to be a cystic lesion and you just get cyst fluid contents. That's unsatisfactory because that's not a diagnostic aspirate, right? It could be papillary cancer. It could be a benign lesion. You can't tell the difference until you actually sample some solid tissue in that. Does that make sense? Benign? Well, benig's easy. You get a diagnosis of benign, you know what you're going to do clinically. You're going to watch the patient, treat them, but don't do anything surgically. And then, of course, there are all the others where you're probably going to be thinking about surgery. And I'm not going to talk about what surgery because that's the surgeon's decision, but this is the interactive thing where you have to have your clinical pathologic correlations around what surgery to do. Generally speaking, malignant means malignant. That doesn't always mean surgery, by the way. Let me challenge you guys to think a little bit. What malignancies would you not send to the surgeon? Well, you might have a lymphoma. Lymphoma is malignant, right? A good pathologist will tell you it's malignant, but it's lymphoma. And those aren't necessarily going to be treated surgically, right? So the point there is malignant it doesn't mean papillary cancer or follicular cancer. Malignant can be any malignancy, and each malignancy needs to be treated differently. So you may have I'll get speculative here because everybody's practice differs, but let's say a 1.8 centimeter follicular lesion in a young woman, solitary, and it comes back papillary thyroid cancer. There are lots of places where that still might be a hemithyroidectomy, right? Low-risk thyroid cancer. So being malignant doesn't mean specifically a surgical outcome of total thyroidectomy and neck dissections. But that was just to bring that issue forward. The other malignant diagnosis that you might not operate on is anaplastic thyroid cancer, right? If it's like a huge mass, extrathyroidal, and blah, 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 they may not elect to do surgery. But at least you know you've got a definitive diagnosis. The rest, those other three are the ones. How many of you went to Scott Berner's talk this morning? I see only a few hands, not a lot. So Scott Berner talked a whole 40 minutes about what to do with all these others, the suspicious, the follicular neoplasm, the atypia of uncertain significance. These are all different degrees of pathologists I don't know. And if I don't know, I can't tell you for sure anything. Our goal as pathologists is to move more of those into the clearly benign and clearly malignant category with ancillary testing like molecular. And there were a few folks who told me that's been their message at this meeting, right, is how much molecular I need to know. But the point is that all of these are going to be the ones where you need to work with your surgeon on, okay, how good is our pathologist? How many of these turn out to be malignant and how many of them are usually benign? And that's how you can judge your clinical risk for how much you want to push total thyroidectomy versus lobectomy. Most of these, except for the atypia of undetermined significance, the neoplasm, suspicious for malignancy, those all need at least tissue to make a real diagnosis. The atypia of uncertain significance, you need to know your pathologist, because your pathologist may lump anything that they don't want to deal with into that bag. And if they're doing that, they're not helping you. So my last slide about cytology is what about the commentary? So when you get atypia of uncertain significance or suspicious for neoplasm, one of the things I worry about is that people then start reading in the bottom lines, the descriptions and all that, and they see, oh, they described grooved nuclei, they described Samoma bodies, they described calcifications and stuff like that, and then you start double reading your pathologist. So if your pathologist is good and you see something you don't understand, my advice to you is call them and ask them, what did you mean? Why didn't you call this papillary cancer? You saw grooved nuclei. They might tell you, well, there are also lots of lymphocytes there and this could be thyroiditis. Because thyroiditis and papillary cancer look the same on cytology except for the lymphocytes around the cells that have the atypia. But the other side of it is, of course, if your cytopathologist is not so good and they're the kind that lump everything into that AUS or FLUS bag, you've got a problem, and you've really got to work with your cytopathologist to make them a little bit more definitive. Like, don't call everything AUS. That doesn't help me. I didn't need to do the biopsy if that's all you're going to give me. I need you to do better. Don't try and make the diagnosis yourself. This is what I get worried about. Some endocrinologists think, well, I know thyroid better than my cytopathologist who does mostly gynae stuff, right? And I'm going to read their descriptions, and when I see these things, I'm going to make the diagnosis. That could get you into trouble. And the other thing, which I just need to remind you, because I see this a lot, is endocrinologists don't get what they want. They repeat the biopsy, and they keep repeating the biopsies. When sometimes it's better to just say to your cytopathologist, send that biopsy that I already did for review to somebody who's a real expert in this field. Because repeating the biopsy just makes it harder and harder and harder for the pathologist who's reading it. Every time you do a biopsy, you induce reactive atypia in the thyroid, so the next biopsy is going to look worse and worse and worse every time. So it's much better to get that first one read properly than to repeat the biopsy and keep getting the same nonsense back. Does that help a little bit? Questions? Wow, great. That's the effect of the Bethesda meeting. Fabulous, good, I'm glad to hear that. Any other questions for me now? Okay, so we've got a patient, oh, yes. Yeah. So that's a great question. Yeah, if you go back to the categories, non-diagnostic or unsatisfactory, the question was, does it help to have a pathologist there when you're doing the biopsy? And that's the issue of adequacy. So in my institution, for example, my cytopathologists, we encourage our clinicians to send the patients to us. We do the biopsies. Because when the cytopathologist does the biopsy, it's not that they do them any better than you guys. You can do them really well. That's not the issue. The issue is twofold. One is sample preparation, and the other is on-site evaluation of the specimen. So a cytopathologist with a patient in front of them, they can stick a needle in, do the biopsy, prepare a slide and look at it and say, do I have enough diagnostic tissue here in this biopsy to actually make this not fall into that category of you got to repeat it? So that's the real benefit of having the pathologist either there with you when you're doing it or do it themselves, because they can actually do the evaluation on site. The other piece is the preparation side. Some of you get great aspirates. My husband's guilty of this. He does beautiful aspirates, gets tons of tissue, puts it on the slide, and smears the slide so thick that we can't see it. So the pathologists or their technologists, you don't need a pathologist there for that. If you're the kind of person who always gets great adequacy but the preps aren't good, we can provide cytotechnologists to come and help you when you're doing your FNAs, and they will make sure that those slides are smeared properly so we can actually look at them, and they'll put some into fancy liquids and all that stuff to make sure we can do molecular and all the other things we need to do with those biopsies. Question at the back. So FNA of lymphoma is interesting. That depends on your cytopathology service. We do our own at our place, and we actually immunophenotype lymphomas based on, like our cytopathologist would do a thyroid aspirate. They'd look at the slide. They'd see that it's all lymphocytes. You get some atypia in lymphocytes. Now that could be thyroiditis, so that's the big differential there. And then the issue is it monoclonal or polyclonal? So you can do it by pure molecular analysis if you use that thin prep stuff where you just stick it into liquid and the RNA and DNA are really good. You can do clonality studies and say it's monoclonal and it's lymphoma. Or if you're in a place that has even more sophisticated approaches, you can take a second pass and use that for immunophenotyping and come up with a definitive diagnosis of what kind of lymphoma on the cytology, so the patient can then go for chemo or whatever else would be the appropriate for that. Well, the pathologist should, a good cytopathologist should be able to say this looks like lymphoma, not, I mean, they'll tell you it's not carcinoma. That's an easy one. There are lots of conventional, simple markers that even if they're not entirely sure, any routine cytology preparation can be stained for an epithelial and a lymphocyte marker. And then you know you're dealing with a lymphoid lesion rather than an epithelial one. Although I have to say 90% of the time, just looking at the slide, most pathologists will say, that's lymphoid, it's not epithelial.
Okay, so what do you consider an adequate sample? What should the fellows know about?
Well, okay, so that gets controversial. And adequacy depends on the technique you're using. So both whether is it a smear or is it thin layer. How many of you still, when you do your, you all do FNAs, I'm assuming? When you do your FNAs, how many of you put them on the glass slide and smear them, and how many of you put them into a liquid tube? First, smears. Lots of you still. Some of you do both. Excellent. So the definition of adequacy depends on the sample prep. In the old days, when you only did smears, there was a very rigid, I don't know if you've ever heard of the Kinney criteria, where you had to have a certain number of clusters of epithelial cells with a certain number of cells, and then, you know, all these fancy criteria. That's actually changed a lot. So adequacy now is not as rigidly defined when you go to thin layer. So if you're putting stuff in a tube, we actually can get away without the old criteria, and it's much more sort of pathologist interpretation dependent. Do I have enough cells on this smear to actually be able to make a definitive diagnosis? The adequacy issue is probably very much dependent on the pathologist's expertise in thyroid. If you've got a cytopathologist who's doing 2,000 FNAs a year, their adequacy criteria will be far less than those of a pathologist who's doing 50 or 100 a year. It's like anything else in life. The more you see, the more you start to become good at it. And so the old Kinney days, when there were very strictly defined criteria for adequacy, have kind of gone out the window unless you're still using just that technology. Well, so that depends again on your lab. If you use a lab that only does smeared slides, yes, definitely. The more the merrier, and make sure that those smears have lots but not too much so that they're clumped too high and the pathologist can't see them, right? But if you're using the thin layer stuff, no. Make one good smear and put the rest into liquid, because we can do a lot more with the liquid than we can with the smear. The smear really is our cheating way of doing histology and cytology. It gives us architecture. And there's a lot of value to seeing architecture, but there's much better value to seeing nuclear morphology, and potentially, I hope you're starting to understand, doing other things like molecular testing. And that's all better done in the stuff in the tube. So that tube actually goes to the lab, and it's the cells are, all the blood gets lysed. It's out of the way. We don't want red blood cells. And you end up with only the epithelial cells that you're looking for, or the lymphocytes if it's a lymphoma, being settled very nicely and singly on a glass slide that the pathologist can see. We can make multiple slides and use them for things like immunohistochemistry or FISH, or we can take the tissue right out of the tube. It's a great preservative for RNA and DNA, and you can actually use that for molecular studies. So I would say make one really good smear and put everything else in the tube if you've got a lab that has that thin layer technology. Yeah, so that's really a great question, and it could take me about 2 hours to answer that. I'll answer it really simply. Virginia Lavolsi published this a long, long time ago. She calls it WAFT, because she has a New York accent. Worrisome histologic alterations following FNA of thyroid. And it is absolutely horrible for a pathologist on histology to look at the tissue around a biopsy site. It looks like papillary cancer. That's exactly what it is. It looks like papillary carcinoma. So every time you do an FNA, every site where you've aspirated in your multiple passes, you've essentially induced a reactive atypia that if you FNA it again, is going to be more likely to be miscalled for papillary cancer. Now, I'm saying miscalled because I actually worry about this. Very extensive practice. I won't admit how many years I've been seeing these samples. We see a lot of patients who have an FNA benign, FNA atypia, FNA more atypia. When the thyroid comes out, they've got cancer. Are we inducing it? Or is it all just reactive? Am I misdiagnosing it? This raises a lot of really serious questions. So my point is just to say, don't repeat the FNA, especially not very soon after a non-diagnostic one, because it does get better over time usually. But this is a big pitfall. That's a great question, too. I can't give you a real answer. Don't do it in 3 to 6 months. 6 months to me would be the minimum for a repeat, because the atypia at 3 months and less is so bad you don't want to see it. Even at 6 months, there's still some, but it becomes much more walled off and localized. Fabulous question. Your pathology report is only going to be as good as the clinical information your pathologist has about the case. Everything is context, right? And we're no different. I know people think of pathology as this black box. You stick in a sample, you get a number. That might be true in chemistry. Even there, we know there are problems like hook effects in assays and so on. So no, it's not a black box, and this is very interpretive. Always, 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 please give your pathologist relevant clinical information. Cold nodule, young woman, well, we usually know we know patient's name, age, sex. We get that as part of our report. We don't know anything about the clinical history, and this is the perfect example. Atypia in Graves can look like papillary cancer. And so for us to know that the patient has Graves and it's a cold nodule being biopsied, we know we want to be looking for two populations of cells. There may be a few cells with atypia that look like they're worrisome for papillary cancer, but that could be the non-tumorous tissue that you got on the way in or out. So absolutely, clinical history is critical. Hot nodule? Wow, please tell me. Please, I don't want to overdiagnose cancer. My opinion would be treat them and wait and see what happens. I mean, you don't want to be confused by that background noise. And so, I mean, unless it's something that's rapidly growing where clinically there's a different indication, always wait. Always give us a chance to let it cool off and see what happens, right? Absolutely.
Okay.
Okay.
So we're moving on to surgery now. Dr. Doherty.
Okay. Well, good afternoon, everybody. It's hard to follow Sylvia to doing these things, but the good news for you all is she'll be back in a minute, so it won't be very long. So I'm going to talk about communication about the surgery, or from the surgeon to the other people who are taking care of the patient, and how we might make that better in more broadly than it is now. How many people here dictate notes when you see patients in the office? How many people write notes? How many people don't have to record anything at all when you see patients? Good, there were no hands there at the end. So, and how many people think that all the things that you dictate or write down or record for your patients are perfectly clear, inclusive of all the things you want to have in there, and exclude all the things that you don't need to have in there? Is there anybody who's convinced that all your notes are perfect? Yeah, just Andrew. So we have the same problem with op notes, but it's probably more important with op notes. How many people read op notes? How many people have ever seen one that was really confusing? Okay, so if you see an op note, here's the dirty secret about surgical op notes. If you see two things. One is if you see an op note that's 2.5 pages long and it's one paragraph for a thyroidectomy, the surgeon doesn't know what they're doing. They've got themselves so confused. They're dictating everything, what kind of sutures they used, what the sunspots were when they made the incision. That's a meaningless op note. The other thing is, if the op note was dictated more than 24 hours after the operation was done, the surgeon probably doesn't remember what they did. And there's very clear data about that, and it's an important problem for all of us in the quality of the medical record. Personally, I do my op notes before the patient's out of the operating room, while they're waking up from the anesthetic, for that exact reason. I can't remember anything 20 minutes later, much less more than a day later. Okay, so what should be in a good op note? A good op note should include the indications for the operation, and it should try and set the stage for everybody who goes back to look at that op note later on in the patient's care for what the surgeon and the treating team knew at that point. So it should include why you're operating on the patient. Are you operating for a nodule with and some atypical findings and an unusual ultrasound, and so you're taking this out as a diagnostic operation, even though the procedure line says total thyroidectomy and central neck lymph node dissection, because during the operation you found out it was papillary thyroid cancer and you found out there were positive lymph nodes, you did all this stuff. The indications in there should indicate how the patient got to the operating room to begin with. So indications are important, and they should include preoperative findings, including imaging. The patient's being operated on because they had a incidental PET scan finding. That puts them in a different category for us going forward, and it's important information to record. I think a good op note starts with that part, so the preoperative indications. To me, the best setup is the second paragraph is the findings in the operation. And those findings, for me, fall into two categories. One is the findings about the disease that you observed in the operating room. Is there extrathyroidal extension through the thyroid capsule and into the trachea? Are there grossly positive lymph nodes? Are there, did you find another nodule somewhere else? So describing all those findings. Were there intraoperative frozen section findings, intraoperative pathology consultation about the things? That should be there. And the other part of that findings portion should be information about the conduct of the operation. Were the parathyroid glands identified? Were any of those autografted? Were there lymph nodes that were, were there nerves that were identified or not identified? Was there a nerve monitor used? And if so, not that the nerve monitor has to be used, but if it was used, the findings of the nerve monitoring for the operation should be in there. So those two things should be in the operative findings, right? Findings about the disease and information about the conduct of the operation. That conduct of the operation should also tell you what was removed. Okay, we all say the patient had a total thyroidectomy or they had a subtotal thyroidectomy. Well, that can be a little bit different from surgeon to surgeon. It also can be a little bit different for the same surgeon from patient to patient. Sometimes I do a total thyroidectomy and it's really a total thyroidectomy. I've removed all of the thyroid tissue because the patient's anatomy made that possible and safe. Other times when I do a total thyroidectomy, I left a little collar button of tissue on each side of the larynx next to the nerve because that was very densely adhesed there, and I thought it was safer for the patient for me to leave that and have less risk for their nerve. So that's something that's dictated by the patient situation. It should be somehow discernible to you in the operative report. So what was removed, thyroid, lymph nodes, any other things, what was left behind, parathyroids, nerves, and so on. I don't have any slides, but I do have these notes, which we can auction off at the end. Yes, please.
From our standpoint, obviously.
And it will be important also if you're, you do an ultrasound, you do radioactive iodine, and it shows some uptake, and you do an ultrasound 3 months later, and there's a hunk of stuff there. Now you don't know whether that was that thyroid tissue that was left deliberately behind because of the way the original operation went, or is this cancer recurrence, and it can be very confusing. If we FNA that, Sylvia's going to kill us. Because then it's a real problem interpreting. So that's what a really good operative report looks like. But I would venture to guess that most operative reports are not really good. And I suspect that most of the operative reports that you all see are mediocre. I mean, they may not all be that 2.5-page, 1-paragraph thing that you can't get any real information out of, but some of them I suspect are pretty poor. So one of the questions for surgeons is how we can make that better. We try with things like requiring medical records to be completed in 24 hours and stuff like that, but that has not been very effective. I think some of the most innovative approaches that may be present in some of the institutions that you're in are electronic synoptic operative reporting. The pathologists have been way ahead of us on this. How many people have synoptic pathology reports? Does anybody know what they are? When you get a pathology report and it has a list of items, the size of the tumor, they basically stage the tumor, give you all the information in a little table in the operative report. That's called synoptic pathology reporting, and the reason it works is because the pathologist has to fill it out to finish the report. Right? So you have to fill in all these things in order to have the report be done. So all the information that you want to have in the report gets there. And so what I hope in 10 years will be standard, and it has become standard in some places now, is synoptic operative reporting. So that if you do a thyroidectomy, you would have to include all of these things in the report in order to have the operative report be complete. And there are systems now for doing that, with parts of it by free text, parts of it by drop-down menus, and so on. Actually, I think Alberta, Canada, Gianoukakis has now made this a province-wide standard for operative reporting. There it's a model for all of us. I know Memorial Sloan Kettering has a similar system where they have operative synoptic reporting in order to try and get all this information in there. That's probably not going to happen right away in all of our hospitals, though, as much as we might like it and as much as EPIC might try and push us there. So the question then is, what can you do when you're faced with that mediocre operative report? And I can tell you what I do. As somebody who does a lot of reoperative surgery, I'm faced with a lot of mediocre operative reports and trying to figure out what the surgeon did at the first operation so that I can understand what might be necessary in the next one. And I basically make a synoptic operative report. So when I read one of those reports, I go through and write down what I would have put in an operative report, sort of abstracting it out of that poor report. And then I either dictate that into my office note or I hold on to it with the materials that's going to go to the operating room with the patient so that we've got that information somewhere. And I'd encourage you to do that as you work with all different surgeons. If the operative reports aren't good, try and fill out a synoptic operative form for yourself so that you know what happened. And if you come up with blanks in there, you can try calling the surgeon and asking them. But I think if it's more than 24 hours later, you're probably not going to get a real answer. So, yes, Andrew.
Dr. Doherty, when the fellows get these groups of lymph nodes,
That's a great question. So I'll take the thyroidectomy question first. Most of us now do total or near total thyroidectomies for most situations, for most initial operative situations. So if we're going to remove a lobe of the thyroid gland, we remove it completely with the exception of potentially leaving, again, a little collar button of tissue next to where the nerve inserts if it's not as safe as we would like to dissect that spot out. And that's called a near total thyroidectomy. So I would sort of lump those two things together as an attempted total thyroidectomy, if you will. A subtotal thyroidectomy should be pretty much a historical operation at this point. So subtotal thyroidectomy, as it was practiced for decades, involved a whole bunch of clamps. Everybody here has been in the operating room, right? A whole bunch of clamps and actually cutting across the thyroid gland in a plane like this. So you left the posterior part of the thyroid gland in the tracheoesophageal groove. So they would sort of clamp across the middle of the gland and cut between the clamps and do this about 10 times, and you ended up with all these clamps, and then you oversew all the clamps, and you've left the back portion of the thyroid gland. It leaves a lot of thyroid tissue in place. But more importantly, the reason we don't do it very much now is because it's not as safe as a total thyroidectomy. In the classic subtotal thyroidectomy, you don't visualize the nerves. You don't look for the recurrent laryngeal nerves. In fact, there's George Kreil, who was a very famous thyroid surgeon a few decades ago, wrote that if you see the recurrent laryngeal nerve, you've already injured it. And that was kind of the standard dogma at the time. So they tried not to see the nerve, and they left a lot of thyroid tissue in place. I'd say that's sort of flipped completely, and maybe that should be a mark of a bad op note. If you see somebody say they did a subtotal thyroidectomy, they're probably older than me, and I'm not that young anymore. So that's my sort of summary on the reporting that you should try and get from us. Oh, I'm sorry, lymph nodes. Lymph nodes are categorized by levels. Has everybody heard about the levels of lymph nodes? So level 6 is the compartment that includes the thyroid gland. It goes from the hyoid bone down to the sternum and carotid to carotid, so it's that central neck compartment. And then the lateral neck lymph nodes are levels 2 through 5. So 2, 3, and 4 go down the jugular vein. 5 is posterior triangle, so posterior to the sternocleidomastoid muscle. And level 1 is generally irrelevant to thyroid cancer. It's at the submental nodes. Usually if those are involved, kind of everything's involved. That's an unusual spot for thyroid cancer to be. So when your surgeon describes doing a lymph node dissection, they should tell you what levels of lymph nodes were removed. And they should, and with level 6, they may even subcompartmentalize that a little bit and say they did an ipsilateral level 6, meaning the paratracheal lymph nodes on the side of the cancer. And they may have not done as thorough a dissection in the other tracheoesophageal groove in order to try and protect the parathyroid glands and lymph nodes there. So those things should be spelled out by level in, again, a good operative report. And unfortunately, they're not all as good as they should be. The other side of that communication is the communication back to the pathologist. So, we complain about the information we get from pathologists. They just, they didn't find all the lymph nodes. They didn't count them all up. But we don't always tell them what we've taken out. And so the pathologists get this sort of lump of stuff, and they're supposed to reverse engineer where it came from and what it should be. And so the part of the good performance of an operation, I think, is appropriately designating what the specimens are. Some surgeons have standard things they do, like putting a stitch on one side of the thyroid gland upper pole so that you can keep from getting it flipped left and right. And then I always I send each compartment lymph nodes separately. So level 2, level 3, level 4, level 5, level 6 are each a separate specimen. for two reasons. One is so that we get the information back accurately, and the second is it keeps the pathologist honest. They've got to find some lymph nodes in there if I sent them a separate specimen. So, what questions can I answer? Yes, sir. So it's the tubercle of Zuckerkandl, actually, the organs in the belly, right? So Zuckerkandl got around. So that area of the organ of Zuckerkandl is that spot that I'm talking about that we may leave a little bit of tissue in doing a total or near total thyroidectomy, but it should really be a little bit. So on post-thyroidectomy ultrasound after an operation for thyroid cancer, the carotid should be up against the larynx. There shouldn't be enough tissue in there to displace the carotid laterally. It's usually a little bit further lateral in the left because of the esophagus there, but there shouldn't be visible tissue at that point. Not that there isn't sometimes, but there shouldn't be. We have patients come in with all different levels of thyroid resection expertise. You know, these people who've had a total thyroidectomy, but their TSH is normal on no replacement, and so you have to read a little bit beyond just the line of what the surgeon says they did as the operation or what's they charged for. Yeah, they are, but they aren't admitting it. Yeah. Yes, sir. Sure. Yeah, it is actually a great paper. I think it's in one of the otolaryngology journals where they went through terminology for neck dissections, and it goes through all of that. But basically, lateral neck is levels 2 through 5. Central neck is level 6. So if they say they did a modified radical neck dissection or a lateral neck dissection or a functional neck dissection, all of those things should include levels 2 through 5, which should be the equivalent there. And then central neck dissection or level 6 dissection should be equivalent. And then this rare, in our situation, rare submental dissection. So, good question. Yes? I wouldn't assume anything. No, and in fact, there are instances when they do. There are probably not instances when they should. So I would say the most common time somebody will have had a lateral neck dissection and not a central is if they had an initial total thyroidectomy without a central dissection, and then their recurrence is lateral, and so they just did a lateral neck dissection. The patient's never had the central neck dissected. But 90% of the time, if there's lateral neck metastasis, there's also central neck metastasis. So they probably shouldn't do that. But I wouldn't assume just because they say they did lateral that they also did central.
All right. Thank you. Mark, specifically labeled and sent to pathology along with the thyroid.
So I'm just going to make a little comment on that was a fabulous presentation. I loved it. In Canada, subtotal thyroidectomy is a billing code that pays more than a hemi or a lobe. We get subtotals all the time, but they're really lobes or hemis. But so read your pathology report too, because the pathologist has to keep the surgeons honest, and whatever we get is what we're supposed to say we got. So anyway, we don't want our surgeons to be poor. We just want to make sure the patients know what came out. Okay, so the pathology report. So the questions I asked that I think you should want to know is, what do I need to read? And I think you started this discussion really well with this whole issue of synoptic data. Most of you, I think, put up your hands that you're actually starting to get pathology reports that have synoptic data. So the important fields for you, first and foremost, there should be always in every pathology report a diagnosis field that actually summarizes what's the key element of the report. Not all pathologists do this, but I teach them that this is what they're supposed to do. And I'll give you a simple example. We operated on this patient who had a 4-centimeter thyroid nodule. You did a total because it was suspicious, and your cytologist says, it's suspicious. That usually means it's cancer. We get this total thyroidectomy. And I get the pathology, and I've got a cancer that's a papillary cancer, but there's angioinvasion all over the place in this, right? That's something I really want you to know about right away. So I start with angioinvasive, papillary carcinoma, 4 centimeters, with extrathyroidal extension or without, whatever. What are the really key elements that you as a clinician need to know about? Then, if there's something unusual about the case, I've put a comment in. And I know pathology reports are formatted in all different ways across every institution and every lab in the country. I've been pushing for a long time for a lot more standardization of this. To me, diagnosis should be the first line at the very top of your pathology report, because that's what you want to read. And then if there's a comment, that comment better be important and it better be in there. So I only make comments when there's something unusual about the case. And the comment is something, again, I really want to draw your attention to. Like, the surgeon said it was a total thyroidectomy, but we only got one lobe. Or something really like, what's different about this case? Or maybe, I'll use medullary carcinoma. We have to talk about that at some point, right? I get a medullary carcinoma specimen, and I see C-cell hyperplasia in the background in both lobes. I'm going to put that in the comment section. This patient needs genetic germline testing, right? Because there's a very high likelihood that this patient has familial disease. Those are the things you want to really read. And then, of course, there's this whole new era of synoptic data. Now, the synoptic data started off as something simple, and it's grown, and this is really being driven by our attempts to capture two things: completeness of reporting and data. If you issue a synoptic report, you're doing it in a way where all that data can be captured so that down the road we can easily pull out all well-differentiated thyroid cancers that had angioinvasion, and we can analyze those for outcomes very simply, right? So synoptic data has pros and cons. If you look at today's thyroid cancer synoptic report, it goes on for 2 pages because the pathologists have to put in every size of every lobe and the isthmus and how big each of the neck dissection parts was. Like, it goes on and on and on. So do you really want to read all of that synoptic data? You have to get to know your pathology reports to know where you want to focus on. But synoptic data is good because that's where the pathologist has said they've had to stop and think and answer a very specific question. The question is, do you need to read all the rest of it after that? And in my reports, the gross description and microscopic descriptions are at the end of the pathology reports, because in my opinion, you guys should never have to read there. And, you know, we kind of make jokes, but we say, you only capture surgeons' attentions for a couple of minutes, so put everything in the diagnosis and comment, because that's all they're going to read, right? And then the endocrinologist is going to go through all the synoptic data and find all the other stuff in the background. Don't go any farther than that, because that's for us. That's our documentation. Gross descriptions are our medical legal protection. That's all it's there for. What did we get? How big was it? What did it weigh? Document what the surgeons gave us, and so on. Don't waste your time. And microscopic descriptions, for me, I tell my pathologists, don't even bother. Why do it? It's all there on the slides. Anybody can go back to it. You don't need to document it for medical legal purposes, and nobody reads it anyway, so don't waste your time. Get it all up front where it matters. So what are the difficult areas for you now? So you've got your report, you've learned your pathologist style, you know how to read their reports. When do you start asking questions? Borderline lesions. What are borderline lesions? So there's 2 different kinds of borderline lesions. Is it borderline benign or malignant? Or is it a borderline malignant to like bad tumor? Those are the kinds of areas where you want to know your pathologist style so you know who to talk to when you have a question. How many of you have diagnoses that are uncertain malignant potential? Oh, I feel sorry for you, sorry. You got to get to know your pathologist to know when they throw things in that garbage bag that means nothing. If you've got a pathologist that you work with a lot, my advice to you is get to know them and understand their language. My surgeons and my endocrinologists who work with me, they know my style, they know exactly what I mean. When I say angioinvasive, they know what that means. That means that patient's not going to do well. When I call it papillary carcinoma follicular variant, they know what they're dealing with. They're dealing with one of those kind of follicular lesions that some people might call benign, unless I say something more worrisome about it. Okay, let's talk about some of the other ones. I don't want to be too late here because we're over time, but the areas of dispute in pathology of thyroid are capsular invasion, lymphovascular invasion, and extrathyroidal extension. So just these are like my disclaimers. When we talk about capsular invasion, make sure you know whether your pathologist is talking about the tumor capsule. There are some pathologists who use this to talk about the thyroid capsule, and I hope you'll agree with me and we won't argue on this. The thyroid doesn't have an anatomical capsule. So for a pathologist to think that they're talking about thyroid capsules, there isn't one. Okay, so what they're talking about, or they should be talking about, is this was a tumor that had a capsule and we saw invasion through the capsule. In other words, it's really malignant, not benign. Then there's this whole issue of lymphovascular invasion, which I object to. I never use the terminology, even though it's in the College of American Pathologists synoptic report, because there's a really big difference between lymphatic invasion, which at least 50% of papillary cancers have, and it only means that there are positive neck nodes, and angioinvasion, which means distant metastatic spread, blood vessels, not lymphatics, right? So again, get to know your pathologist and what that terminology means for them. And extrathyroidal extension, another area where pathologists never agree. There's fat in the thyroid, so seeing invasion of fat doesn't make it extrathyroidal extension, but a lot of pathologists who don't do much thyroid pathology don't know that, and they will call things extrathyroidal extension when it's not real. So again, get to know your pathologist and what they do. When should you call the pathologist? My advice is call the pathologist more than you do now, because pathologists like to hide in the lab and take no responsibility for their patients, and if you guys make them understand the clinical significance of what they're doing, they will do a better job. Right now, they're in there looking at slides. They think they just push glass and issue reports. And many of them, I hate to say this, they're my colleagues, they forget that there's a patient at the other end of this. And they need to understand what they need to do better for you to treat your patients. So stay in touch with them. Whenever you have a question, whenever there's a discrepancy between what the pathologist says and what you thought clinically, talk to them. They will learn from you. They will learn by going back. They'll go back and look at the slide and say, oh, maybe I missed something here. Whenever you need more information, whenever there's anything unusual about a case, talk to your pathologist. Get them stopping from looking at their shoes and their hands to looking at you and talking with you. This is really, really important for good multidisciplinary patient care. So here are my key messages. Get to know your pathologist. I think that's really, really important. Every pathologist is different. Some of them have more experience, some have less. The ones who have more tend to know more about the clinical relevance of what they're doing, but a lot of pathologists only see 5 or 10 thyroids in a year, and they don't understand what it means to you to get a report that has information that you're looking for. So educate your pathologists. And last not least, don't be afraid to ask for another opinion. Most pathologists don't mind. Some of them will get upset, and if they do, then you've got to teach them a lesson, because we all make mistakes. I am never afraid to send a case out for a second opinion if somebody wants me to, and sometimes I do it spontaneously. Many busy pathologists in practices, especially private practice where they're generating their income by pushing the glass, they're too busy to think about it. But if you ask, they're usually very happy to do it. And most consultants are very happy to help you out. So I'll stop there, and questions.